lot of studies are going to be reshaping that space, the adjuvant space of HER2 positive disease. I want to start first with you with the DESTINY-Breast05. Can you tell us a little bit about this study and how it might change the field?
All right, so DESTINY-05, at the time we're having this conversation, has not been presented, but there is a press release and it's going to be presented about a week from today. And that data is expected to show a significant improvement in the likelihood of recurrence when compared to T-DM1, and will probably make T-DM1 no longer the standard of care, and it will become the new standard of care in reducing the risk of recurrence. But what is DESTINY-05? DESTINY-05 is a study with trastuzumab deruxtecan. So it's another ADC. It's a superior ADC, which we already know, to T-DM1, so it's not shocking that it will be superior to T-DM1 in the adjuvant setting. But still a monoclonal antibody-based therapy. It's still based on trastuzumab, which we have discussed extensively, has limitations in terms of being able to get into the brain. So there will be people who will say, well, this neratinib has not been studied in this group of patients. The truth is this, that's when you go back to your biology. That's when you go back to the science that drives everything that we do in oncology. If you wait for every data to reflect everything that we do, then we will never move forward. My argument will be that, yes, we would maybe, instead of a 50% reduction, we've reduced the total risk to 70%, but the CNS risk remains, and there's still a residual risk that the extended adjuvant therapy gives you with neratinib. So that would be my speculation and my argument, even after the data is presented, no matter the results of the data.
Fantastic. Dr. Kang, how about there is another study that we don't know when it's going to result. It should be soon. I'm hoping in the next few years. This study has been going on forever. It's the COMPASS-HER2 RD. Can you let us know a little bit about the study design and what it's trying to achieve and how it might change the field?
This is also a very interesting design, looking at improving outcomes in high-risk patients who have residual disease after neoadjuvant therapy. At the time of the study design, standard of care is adjuvant T-DM1 for 14 cycles, and the study COMPASS-HER2 RD is looking at randomizing between T-DM1 plus tucatinib. Tucatinib is a different tyrosine kinase inhibitor, small molecule inhibitor that works intracellularly and blocks HER2. And so doing a year of T-DM1 plus tucatinib, is that going to further reduce risk of recurrence in this high-risk population that had residual disease? And then because the mechanism of action of tucatinib is relatively similar to neratinib, although there are small differences between the two tyrosine kinase inhibitors, I think I'm very curious to see if it's going to reduce CNS recurrence as well. We don't have that data yet.
No, we don't have that. It's been a long time coming.